Do you want to live as well as possible for as long as possible? Well, let me explain to you how your doctor will make that happen. I believe we can prevent heart attack. We can put in place strategies to reduce risk. We can literally plan to change your future. I call it Healthy Heart Network. Hi, I'm Dr. Warwick Bishop and I'd like to welcome you back to the Healthy Heart Network. Well, what are symptoms and prognosis? Symptoms simply are what you feel, the things that you describe to your doctor when you're seeking medical help. Doctor, I have a fever. I have a pain in my chest. These are symptoms. And what is prognosis? Well, prognosis is the medical term we use for defining how you will progress. What is the outlook for you or your condition? So basically, if we want you to live as well as possible for as long as possible, we want you without symptoms and with a good prognosis. So today I'm going to talk about people who we know have coronary artery disease already. This is different to what we've spoken about in previous episodes where I've been talking about preventing the condition. But in this situation, we are now clearly defined in a circumstance or a situation which is guided clearly by the literature that's currently available. One of the first things we need to do is try and establish what sort of degree of build-up of plaque is in the arteries that's causing the problem for an individual. Remember, plaque can occur in its early stages as not limiting blood flow to the heart at all. But in the later stages, it can give rise to limitation of blood flow. So as the heart requires more blood because it's working harder, a narrowed part of the artery may prevent that blood getting to the muscle. Also remember that it's not just about whether there's a narrowing or not, it's also about the stability of the plaque. And it is this particular situation, the stability of the plaque, which explains why people can be apparently well 1 minute and have a heart attack the next. And that stability of plaque is really important because it can affect not only the flow limiting plaque, but the non-flow limiting plaque. So you could easily imagine someone have a non-flow limiting plaque that ruptures, closes off that artery completely and causes a heart attack. It is the role of aspirin and cholesterol-lowering medications such as statins to try and stabilise this process and reduce clot or plaque forming within the arteries. When there is narrowing of the arteries, this will often lead to symptoms. This will lead to the symptom of angina, which is discomfort in the chest. It can lead to shortness of breath on exertion, and it can decrease someone's exercise capacity. There are three main ways we can deal with this, but before going into details about how that works, let me just quickly explain to you what a stent and what a bypass are. So a stent is a very neat way of overcoming a localized narrowing in the arteries. We pass a wire through the lesion. This is the plaque that's causing a problem. We then pass a balloon with a scaffold over the top. The scaffold is the stent. When that balloon is in place, right in the middle of that narrowing, we inflate the balloon, and that inflated balloon pushes the scaffold into the wall of the artery, opening it up. We're then able to pull the balloon and our wire out, leaving an opened artery. A bypass is quite different. A bypass requires open heart surgery, and to overcome a blocked lesion, we literally plug another artery or vein beyond the blockage and establish blood flow that way. So let me go on and explain how we use medicines, stents and bypass grafting for patients who have coronary artery disease. Let me walk you through this table. There's only three management strategies we have. One is medicines, another is balloons or stents, and the other is bypass surgery. For symptoms, medicines are pretty good and most of the time give good results for the majority of patients. I've given them 2.5 stars because I have many patients adequately managed just on simple therapeutic manoeuvres. When it comes to prognosis, then medicines are absolutely critical for everyone with coronary artery disease. And that's because they lead to plaque stabilisation, whether there's a narrowing or not. So the statins and aspirin become absolutely critical to the process of reducing a recurrent problem, a second event, or secondary prevention. Balloons and stents are fantastic for symptoms. If we go back and look at this particular situation, you can see very clearly that if there's a single narrowing in the artery, that a stent will open that narrowing up and relieve the symptoms that that narrowing is causing. Importantly though, the prognostic advantage of stents is not as clear-cut. And that again is easily demonstrated on this image. We've put in a stent here, but there's still plaque occurring in other parts of the coronary vascular bed. So stenting doesn't deal with those other areas. What deals with those other areas is the stabilisation of plaque using the medications. Lastly, surgery is considered good for symptoms, but it's not perfect. Patients end up with a large chest wound, which can take a while to heal, and sometimes the arteries can be difficult to graft all of them, but it is very good in certain situations where stenting or medications are inadequate. Prognostically, because surgery is the biggest undertaking, as you might imagine, it provides the most benefit for the sickest patient. So if you can take someone who's got a poorly functioning heart, if you're able to get them through coronary artery bypass grafting, you'll give them excellent prognostic benefit. These decisions, of course, are a little bit more complicated than a simple table, and we regularly have meetings where there are cardiologists and cardiothoracic surgeons discussing individual patients to try and find the balance of the very best solution for an individual. In summary, there are only 2 things that we treat as your cardiologist in regard to your heart. The first is symptoms. We want you to be free of symptoms. And the second is prognosis. We want you to have as full a life as possible. Next, we treat coronary artery disease with only 3 main things. We have medicines, balloons or stents, and surgery. Everyone needs to get medicines for reducing future risk. The statins stabilise clot and the aspirin prevents recurrence of clot. These are fundamental to appropriate long-term prognostic care. 4, stents are great for localised problems, but we're not always sure that they're going to make a difference prognostically. 5, surgery for symptoms or prognosis in the situation where stents and medicines are unable to be successful for that individual. Lastly, medicines, stenting and bypass surgery are all really effective treatments and they improve symptoms and save lives. The absolute crux, I believe, then is to be ahead of the game and find the problem before it causes a problem. Stay tuned because our next case is a 28-year-old fisherman from the east coast of Tasmania. So now you're well informed about symptoms and prognosis. So let me introduce you to Steve, who is the case for this episode. Steve's a 28-year-old fisherman who lives 2 to 3 hours away on the coast. He has a terrible family history of premature coronary artery disease. He's a big guy and he's got a predisposition to putting on weight around the middle. He doesn't smoke and he came to hospital with some chest pain. Retrospectively, looking back on it, it was probably a muscular strain. He wasn't immediately under my care. In fact, he was looked after by a colleague who elected to put him through a treadmill test to see if, by putting him through a treadmill test, he could reproduce the symptom that brought the patient to hospital? Well, he worked a very high workload without any troubles at all, suggesting that there was no clear focal narrowing limiting blood flow to this man's heart. But because of the bad family history, my colleague elected to organise a CT of the arteries just to see what was going on. And this is what it showed. I think you can see really clearly here a large plaque with a small focus of calcium in the middle and dark cholesterol components either side. This is in a young man, and you can only imagine what would happen over time should this progress without any intervention. This is right at the beginning of a major artery running down the front of the heart, and no question that Steve would have suffered the same consequence as the other men and women in the rest of his family. There's also no question that the intensity of therapy that we would put in place for this sort of situation is a high intensity of therapy. Now, my colleague was not familiar with using CT imaging and was concerned, reasonably, about this plaque. I pointed out to him that yes, it is a concern, but it's a non-flow limiting plaque and it really needs preventative strategies in place. Given my colleague hadn't had a great deal of experience with CT and really didn't believe it, for want of a better term, he progressed on to an invasive coronary angiogram in spite of me protesting. This means that we have the opportunity to show what an invasive coronary angiogram looks like in the same patient. This is exactly where that plaque is. And although you may not be used to reading invasive coronary angiograms, I can tell you there is no clue whatsoever that there is potentially a life-threatening plaque within that image. This is a really good reminder that invasive coronary angiography tells us about the lumen or the inside of the artery. It doesn't tell us about the artery wall. Here's a reminder of exactly what's happening. Cholesterol begins to build up in the wall, and then as it progresses, the artery changes shape. We call that remodeling. The artery remodels to continue to allow appropriate flow, maximal flow down that artery until it changes to such an extent that progression of the plaque then starts to come back into the artery. So it's very, very late in the process that narrowing occurs. Here's another example. A patient with plaque clearly visible in two areas, but absolutely no suggestion of focal narrowings within the arteries. This case reminds us of two really important things. The first is that if the stress test is negative, i.e. doesn't show any changes which suggest lack of blood flow to the heart at a high workload, and that the CT looks okay, then it probably is okay. And in that situation, the risk of an invasive coronary angiogram is likely to be unacceptably high. At least, that's my opinion. The second thing that this case reminds us of is that the early stages of development of plaque within the arteries occur within the wall without necessarily having any impact on the lumen or the inside diameter. This is really important because it means significant plaque can build up without any clue whatsoever. This plaque as well, if it becomes large enough in volume, is unstable of its own, and once it does get to a certain size, can then start to grow in. There's no question that the information we have from imaging the wall of the artery provides us extra information in that space. Talking about extra information, I'm going to be answering patients' burning questions in the next segment, so stay tuned. Welcome back. In this patient question, I'm going to share a question with you which put a smile on my face. I got asked about whether I think about mindfulness in the clinic. Well, although I've never participated in any structured learning or courses in relation to mindfulness, I've often kept the concept in the back of mind. Without any training or guidance in the technique, my feeling has always been that mindfulness is a process where particularly in the consulting room, we can step back from the immediate interactions and the situation to try and more objectively understand without being driven or responsive by emotion. We can deal with fact, not feeling. I often think that in the most simple terms, this is just being professional and dealing with patients in a way that is respectful, courteous and understanding of their needs without necessarily being drawn into whatever emotional situation they are in. Often is the case that when we find ourselves in a consultation, which is at times an intimate meeting with someone on an emotional level, I believe it is our role as doctors to deal with this situation in a way that not only protects us and allows us to do our job in the best way possible, but also results in the best outcome for the patient. I remember not long ago a particular example of a patient who came, and I'll call him for the sake of this story, John. John came into my office toward the end of a long day of consulting, and from the moment he sat down, it was apparent he didn't want to be there. Without any doubt, there was a sense of hostility and anger. The body language was threatening, the conversation was short, curt and aggressive. I'd never met this person before. This was a first consultation in regard to an issue related to his heart. As you can imagine, I immediately felt threatened, attacked and defensive by this individual's demeanour. I realised that I didn't want to be here, or more to the point, I didn't want him here in my office. It was then that the concept of mindfulness, which was lurking in the back of my mind, came forward. I put down my pen, I took a gentle breath, and I looked this gentleman directly in the eye and said with a gentle tone, "John, I get a real sense that there is a lot of anger going on in this consultation. To be honest, that doesn't make much sense to me because you don't even know me. We've never met before, so why would you be angry at me? I didn't make you come here. You came of your own volition because there is something wrong with your heart and I might be able to help you. I can't claim to know what is going on in your life as we really haven't had a chance to get to know each other, but right here, right now, the amount of anger that you're bringing to this consultation is going to make it really hard for me to do my job for you. What I would really like is that you could put the anger aside. Then we can connect and work together in a far more positive environment. And there may be every chance I may well be able to help you and make you feel better. So could you please put the anger aside, put the attitude aside, and let's see what we can do to help you." Well, it transpired that this was a gentleman who'd had a previous heart attack, and he had come in with all sorts of symptoms. He was angry because he just was scared and he hated doctors and he hated hospitals, but not for what they were, but what they meant to him. I ended up taking quite a bit of time with John and wrote back to his GP assuming I'd never see him again. I listed about 5 or 6 different interventions or treatments which I thought might be beneficial. There was a bit to sort out given he had not seen anyone for a number of years due to his reluctance to be in touch with the medical profession. By the end of the consultation, we were on much better terms. I shook his hand and I wished him the very best, thinking that was hard work and I would probably never see this gentleman again. Interestingly, about 2 or 3 months later, I walked into my surgery only to see John sitting there in the waiting room. Remembering his disdain for the medical profession and my recollection that I would never see him again, I said, "Hey, John, I'm pretty surprised to see you here. What's going on?" John turned around and said, "Doc, you made me feel so much better the last time. I thought I'd come back and see you again." Well, is there a lesson here? Of course there is. We all need to be mindful of what we bring to the consultation on both sides of the desk. Fear, judgment, care, anger, tolerance, uncertainty, or pressure of external stresses. We all need to genuinely look to connect with the other person sitting opposite us, and sometimes that means we have to look at ourselves. This is the only way we're going to make a real and meaningful difference. That concludes this episode. Thank you for joining me. I hope you feel educated and informed and mindful, and I'm sure you're looking forward to the next episode. So until next time, please don't die of a heart attack. Want to know more? Grab a copy of my #1 best-selling book, Know Your Real Risk of Heart Attack. It's available as a hardcover or a paperback and an audio from Amazon or wherever good books are sold.